This is the Voluntary Motor Pathways Show, examining the motor pathways innervating skeletal muscles in the body and head region. All the buttons in this show have been disabled. The voluntary pathways to the head and body region will be discussed separately, but they both involve basically a two-neuron pathway. This overview of the voluntary motor pathway to the body illustrates a two-neuron pathway. Neuron 1, the upper motor neuron, has a cell body in the precentral gyrus. It descends and decussates in the caudal medulla and terminates on lower motor neurons, which are located in the ventral gray horn of the spinal cord. The voluntary motor pathway to the body begins with the cell bodies in the primary motor cortex of the precentral gyrus. These cell bodies project their axons caudally and form the corticospinal tract that passes through the corona radiata and the posterior limb of the internal capsule, ultimately to continue on into the brainstem and eventually to the spinal cord. The upper motor neurons, or the neuron 1 of the corticospinal tract, have their cell bodies located in the precentral gyrus, and these cell bodies are somatotopically organized so that the lower limb is most immediately represented, then comes the trunk, and then the upper limb as we go more laterally. This is in a similar fashion that we saw in the postcentral gyrus for the primary somatosensory cortex. The axons of these cell bodies project caudally through the corona radiata and then into the posterior limb of the internal capsule, and then next through the crucicerebri of the midbrain level. And finally, we see it here going through the pons. Continuing with the descent of the upper motor neurons in the voluntary pathway to the body, we will see here in this horizontal section that they are passing through the posterior limb of the internal capsule, and they are organized in a somatotopic fashion so that the upper limb is most anterior in the group and the lower limb is most posterior. Filling out that posterior limb of the internal capsule, we see that the somatosensory pathways for pain, temperature, and fine touch are located most posteriorly in the posterior limb. The corticospinal tract continues its descent through the midbrain and is found in the middle third of the crucicerebri. As we see here, the fiber bundles are somatotopically organized so that the upper limb is most medially represented and the lower limb is most laterally represented. Here in the pontine levels, we see the corticospinal tract continuing its descent in the more ventral part of the pons and maintaining a similar somatotopic organization of the fibers. Here in the rostral medulla, those corticospinal tract fibers now form the pyramid that we see on the ventral surface of the medulla. And those fibers, again, are somatotopically organized from medial to lateral, from upper limb to lower limb. The corticospinal tract at caudal medullary levels is still found in the pyramid. Its fibers are still somatotopically organized, but at this level, about 90% of the fibers will decussate in what is known as the pyramidal decussation. And doing so, they will form a lateral corticospinal tract. It contains mostly axons that can be controlling lower limb or upper limb musculature, and those fibers are also somatotopically organized as noted. There is one other group of fibers which does not cross, and these are going to form the anterior corticospinal tract, which is mainly going to have control over the axial musculature. At the cervical cord segment, we will continue to follow the upper motor neurons passing or descending through the lateral corticospinal tract. They are still somatotopically organized so that the upper limb is more medially positioned, lower limb more lateral. At this level, we see an axon peeling off to end in the ventral gray horn, and it will terminate on the cell body of neuron 2 in the pathway, the lower motor neuron. Also, projecting into the ventral gray horn, we have fibers of the anterior corticospinal tract ending bilaterally. These will be helping to control axial musculature. So here we see the cell bodies of neuron 2 in the pathway, the lower motor neurons, whose axons will exit the spinal cord through the ventral root and eventually pass through the spinal nerves, reaching their muscles of destination. And here at this lumbar level, we continue to follow that lateral corticospinal tract and the upper motor neurons within it. Here at this lumbar level, we are only left with basically lower limb neurons that will terminate in the ventral gray horn. We've lost the anterior corticospinal tract because that does not descend much below the cervical cord segments. And here we see the lower motor neuron projecting to the lower limb musculature. So in this overview of the voluntary motor pathway to the head, it is also a 2-neuron pathway, with the cell body of neuron 1 being located also in that precentral gyrus and primary motor cortex. Its axon descends and it's going to form what is called the corticobulbar tract. Most of these end bilaterally upon motor nuclei of cranial nerves. There is one exception, and we'll see that as we go along. So in this lateral dissection of the cerebral hemisphere, we see the cell body of the neuron 1 and the voluntary motor pathway to the head, and its axon is descending through the corona radiata. And now, rather than being in the posterior limb of the internal capsule, it's located in the genial region. It passes through that area and descends into continues its descent into the brain stem. Neuron 1, or the upper motor neuron, and supplying the head musculature, has its cell body in the precentral gyrus. It's the most laterally represented group of cell bodies in that gyrus. Probably takes up the largest volume of tissue in that precentral gyrus also. Its axon passes through the corona radiata and through the genial region of the internal capsule. And finally, here we see again in this horizontal section the presence of the descending corticobulbar tract fibers that are formed by upper motor neurons of the voluntary motor pathway to the head. They are in the genial region of the internal capsule, and you see its relationship to the other groups of axons that make up the posterior limb region also. So the corticobulbar tract also descends through the middle third region of the crus cerebri. Its fibers form the most medial groups of fibers in that area, and they, of course, represent the forward innervation of the head musculature, and that will continue descent through this area. The upper motor neurons of the corticobulbar tract continue their descent, and here in the rostral pons will branch off and end bilaterally upon the motor nuclei of the fifth cranial nerve. And these two nuclei contain the lower motor neurons of the fifth cranial nerve, and these send axons through the portia minor region of the trigeminal nerve, which is the motor root, and they will innervate a total of 8 muscles, 4 of which are the primary muscles of mastication. In this caudal pontine level, we will see the facial nucleus, which contains lower motor neurons that supply motor innervation to the muscles of facial expression. Here we see the corticobulbar tract sending an upper motor neuron fiber to a specific part of that nucleus, and that's the part that controls upper facial muscles. And it's projecting to the ipsilateral side in this case. But that corticobulbar tract also sends fibers to the contralateral side through decussation. And when it does so, it innervates both the lower facial muscles and the upper facial muscles on that side. So as a result, the upper facial muscle groups actually receive motor innervation from both cerebral cortices, while the lower facial muscles only receive motor innervation from the contralateral cerebral cortex. Medullary level, we see the corticobulbar tract sending some terminal branches to some nuclei at this level, motor nuclei. They include the 2 hypoglossal nuclei that contain lower motor neurons that then form the hypoglossal nerve that innervates most of the muscles of the tongue. And then the other nucleus is the nucleus ambiguus, and that services 2 cranial nerves. The glossopharyngeal nerve, which innervates only one muscle, skeletal muscle, and that's the stylopharyngeus muscle. The vagus nerve is the other nerve innervating the skull muscles, which innervates all the muscles of the palate, except for the tensor veli palatini, which is innervated by the trigeminal nerve, and innervates all the muscles of the pharynx, except for the stylopharyngeus, but it does innervate all the muscles of the larynx, all the intrinsic muscles of the larynx. This is just an index of the slides we just covered of the voluntary motor innervation to the body and to the head. The following section we'll be doing with some lesions of lower motor neurons and or upper motor neurons and the findings or deficits associated with those lesions, whether it be at spinal cord levels or at brainstem levels or cortical levels. So examining the voluntary motor pathway lesions, there are 2 classifications of lesions, upper motor neuron and lower motor neuron. The upper motor neuron lesion would involve any part of those neurons that originate in the precentral gyrus or the fiber tracts that are formed from that, such as the corticospinal, corticobulbar tracts, or the lateral corticospinal tract. They all are parts of the upper motor neurons. Lower motor neurons, on the other hand, would be the cell bodies that are found in the ventral gray horn that innervate the muscles, or cell bodies in areas such as the motor nucleus of 5 or the facial nucleus or the hypoglossal nucleus. They are all the lower motor neurons. So in thinking about lesions of the voluntary motor pathway, it could involve just the upper motor neurons or just the lower motor neurons, or a combination of both. In either event, we're going to have a paralysis. How we classify that paralysis will depend on which motor neuron group is involved. The first series of slides we'll be dealing with spinal cord lesions of the upper motor neuron and or the lower motor neurons. In this case, the results of these lesions, you could have upper motor neuron deficits or lower motor neuron deficits, but they would always be on the ipsilateral side of the body. So first we'll look at some spinal cord levels here to examine lesions of the voluntary motor pathway. 3 examples are shown here, resulting in lower motor neuron deficits. And they are spinal nerve lesions, or the peripheral nerves that develop or formed by those spinal nerves. Any lesion of those would result in lower motor neuron deficits. Ventral roots, or the ventral gray horn. All of those impact the lower motor neurons. And if it was a complete lesion that of the nerve supply to a muscle group, you would see flaccid paralysis. No activity in that muscle at all. Atonia, areflexia, fasciculations, which are little twitchings within the muscle that develop. And then finally, because the muscle is not functional, the muscle will die and replaced by fatty tissue, and that's called denervation atrophy, because of the loss of that vital nerve supply to the muscle cells. So to look at the features of an upper motor neuron lesion, we're using a cervical cord segment here, and the lesion site is in the lateral funiculus. And are there any upper motor neuron bundles in that area? Well, we have two, the lateral corticospinal tract and the lateral reticulospinal tract. The location of the lesion will be on the left lateral side of the body, because we're inferior to the pyramidal decussation. And it would extend, since this lesion extends from about C5 to T1, it would really start essentially just below C5, maybe C6 on caudally on the ipsilateral side of the body. And these would be the findings in a upper motor neuron lesion. In this case, the upper motor neurons cannot get a signal to the lower motor neurons because of the lesion site. So the lower motor neurons are basically released from the influence of the upper motor neuron, and consequently they become very hyperactive and function on their own. So we get a situation where there's paralysis, but it's paralysis where there's rhythmic contraction of the muscles or tightening of the muscles. We call it spastic paralysis. And if you do an examination of the patient, they're going to demonstrate increased tone within the muscle, and that's because of the spasticity in the muscles. If you test the tendon reflexes, they're going to be hyperreflexic, so we call it hyperreflexia. We have a situation if it involves the upper motor neurons involving limb muscles, lower limb muscles. We have a Babinski sign, and that means that if you stroke the sole of the foot, normally the toes plantar flex, but in the Babinski sign, the big toe dorsiflexes and the other toes abduct. I have a condition called clonus, which is like a rhythmic contraction of the muscle if you put a stretch force on the muscle. Disuse atrophy because of the fact that we can't use the muscle, and so when you don't use something, it's going to be atrophy. So we call this, and even though the lower motor neuron is viable. And then the clasp knife reflex. If you try to extend, let's say, at the elbow, you're going to get resistance because of spasticity in the biceps muscle. Then all of a sudden it's going to release, and that's called a clasp knife reflex. Please note that there's another fiber bundle here in this region, and a little bit of it's being covered by the lesion, and that's the ALS. And if you see something like this in future lesions, you should try to figure out what would be the deficits associated with involvement of that, even though we're not really focusing on that now. So we want to look at a lesion here that involves both upper and lower motor neuron conditions. Here's this lesion in the anterior funiculus and lateral funiculus and the ventral gray horn. The lesion extends from C5 to T1. What would be the consequences of this lesion? Well, at the level of lesion, we would have ipsilateral deficits in the muscles of the upper limb, and the deficits would be of the nature of a lower motor neuron lesion. The muscles which demonstrate areflexia, atonia, flaccid paralysis, and denervation atrophy. So you cannot demonstrate upper motor neuron deficits associated with these muscles because you do not have an intact lower motor neuron. There is another tract here in the lesion. It's the ALS. And what would be the consequence of a lesion of that tract? Even though it's a sensory tract, we should maybe discuss that here now. What would be the consequence of the lesion of that? The area below the level of lesion, below T1, what would be the findings in that area, in that location? So the findings below the level of the lesion would be those of an upper motor neuron nature, that is, spastic paralysis, hypertonia, hyperreflexia, Babinski sign, and disuse atrophy, just as some of the examples of what you would find. Because now the lower motor neurons are viable. So all the muscular masses on the ipsilateral side below the level of lesion would demonstrate this, especially the lower limb. They would demonstrate all the signs and symptoms related to upper motor neuron lesions. The following slides will be focusing on lesions of the fine voluntary motor pathway at brainstem levels. So we're looking at this brainstem level to demonstrate a lower motor neuron lesion at this level. And what level this is based upon the features. It's the caudal pons. And we'll see that the lesion is known as the lateral pontine lesion and does involve some cranial nerve nuclei in this area at this level. And some fiber tracts are also found in this region. Here are the nuclei and their axons, and there's a fiber tract also that is identified here. We're going to focus on the one right now, and that is the facial nucleus, or the motor nucleus of 5, which innervates all the muscles of facial expression. So one of the main findings is that the patient will have a flaccid paralysis of muscles of the face on the ipsilateral side. This is known as Bell's palsy or facial palsy. There's another situation in which patients can develop Bell's palsy, but it's a temporary situation, and it's probably due to some irritation of facial nerve fibers peripherally that brings that about. The other nuclei we see here, you have the abducens nucleus, which is not involved in the lesion, that innervates the lateral rectus muscle. But two other nuclei that contribute to the facial nerve, we have a salivatory nucleus, that is, and so there, and that facial nerve does innervate 3 secretory glands, the submandibular, sublingual gland, and the lacrimal gland. Those 3 glands may be impacted and demonstrate deficits. And in addition, there's the nucleus solitarius, that is receiving taste fibers from the anterior 2/3 of the tongue on one side, and that patient may have some deficits of taste. As a result, the spinal tract of 5 is carrying descending pain fibers, and combined with involvement of the ALS or spinothalamic tract, this patient's going to have some pain deficits. The involvement of those two resulted in alternating analgesia. That is, on the face, there will be ipsilateral loss of pain. On the body, there will be contralateral loss of pain. Also, there's a little bit of the medial meniscus involved here, so we'd expect some deficits of fine touch, probably in the region of the lower limb. Using the image from the previous slide, we're going to look at the medial lesion of this area, of this level. We see that the axons of the abducens nerve are involved, as well as fiber bundles of the corticospinal and corticobulbar tracts. Because of the involvement of the abducens nerve, the lateral rectus muscle ipsilaterally will demonstrate flaccid paralysis, so that that eye would not be able to abduct on that side. The results of the corticospinal tract lesion would result in contralateral upper motor neuron deficits on the involving primarily the upper and lower limbs. The trunk will not have complete loss of function of those muscles. The involvement of the corticobulbar tract will not really cause much of a problem, because the motor nuclei caudal to this level, which would be the hypoglossal nucleus and the nucleus ambiguus, they receive bilateral input from the cerebral hemisphere, so that there would be maybe weakness in the muscle supply by those nuclear groups, but there wouldn't be complete loss or demonstration of a upper motor neuron deficits in those muscles. This slide basically summarizes the consequence of the lesion caudal to that lesion site. And if you want to read further detail here, you may. The following lesions will be centered in the area of the internal capsule and the motor cortex. So we're looking here at a horizontal section of the brain, which we've seen previously in other shows. And this is being shown here because the next slide does show a lesion in this area. And just to review, the internal capsule is a V-shaped mass of white matter situated between the head of the caudate and thalamus medially, and the lenticular nucleus laterally. It consists of the anterior limb, posterior limb, and genu. And contained in there are very important bundles of the voluntary motor pathway, as well as the fine touch and pain and temperature pathways. The head is found at the genu, head region, for voluntary control, and then posterior to that, in the posterior limb, we have those projecting to the body, and the upper limb, trunk, and lower limb are shown somatotopically organized. And immediately posterior to the lower limb, the rest of the internal capsule contains the fibers of the fine touch and pain and temperature pathway. So you can imagine a lesion in this site would result in a broad spectrum of deficits involving not only motor function, but also sensory deficits associated with the lesion. So here we have a horizontal section similar to the previous section, although there is some abnormal tissue in the areas shown by the arrows. This is necrotic tissue that results when you have an occlusive stroke that deprives the brain tissue of blood supply. This happens to be in the area of the genu and posterior limb of the internal capsule. Because of that, corticobulbar and corticospinal fibers would be involved, and so the patient most likely, if they survive this, would have had spastic paralysis of the lower facial muscles on the contralateral side, as well as spastic paralysis of the muscles of the body on the contralateral side. Involvement of any sensory pathways, such as fine touch pathways or pain and temperature pathways, could have occurred to a certain degree also. So in this example, there's a shaded area of the left cerebral hemisphere that encloses the head region and upper limb and trunk. Parts of the precentral gyrus. The lower limb doesn't seem to be involved. And this, as a result of this, there would be spastic paralysis on the right side of the body, mainly focused in the upper limb. The trunk may demonstrate weakness, but those muscles tend to get a bilateral control from the cerebral hemisphere, so that there may be just weaknesses there. As far as the head region, the main impact will be on the lower facial muscles on the right side, which will demonstrate a paralysis of a spastic nature of the muscles of facial expression.